Welcome to the deep dive. Today, we're really getting into how doctors figure out what's going on with your arteries.
Yeah, it's like learning to read the body's signals, isn't it?
Exactly. And our main source here is Rutherford's Vascular Surgery and Endovascular Therapy. Pretty much it's the gold standard text.
Absolutely, it's the go-to.
So the plan is to break down how clinicians assess arterial health, focusing a bit on the legs and, how they connect your story, your symptoms, to what they actually find during an exam.
Right, and for you listening, this should give you a real sense of the logic behind it all. It's not just random symptoms. There's a structure to how doctors think through these things.
Hopefully some aha moments along the way.
That's the idea, seeing how it all fits together.
Okay, so the book breaks it down into two main parts, right? The clinical history
For sure.
and then the physical exam, what the doctor finds. Let's start with the history. How important is that initial conversation?
Oh, it's crucial. The chief complaint, what actually brings you in, that's the starting point.
The main reason you're there.
Yeah. And what's really interesting is how often that complaint points directly to physical findings. Like, say, someone comes in describing pain in their buttock or thigh when they walk claudication.
Okay.
An experienced clinician immediately thinks, sounds like aortoiliac disease. That's the big arteries going down.
Right.
And they'll already be expecting to find weaker pulses in the groin, the femoral pulses.
So the story sets an expectation for the exam.
Precisely. It's that first link.
But what if they don't match up? The story says one thing, but the exam shows something else, or nothing.
That's a really important point. If there's a mismatch, you absolutely have to question things, rethink. Maybe the initial idea was wrong, or there's something else going on.
So what kind of symptoms are we generally talking about with arterial disease?
Well, the book lists several broad categories. There's pain, obviously. Weakness in the limb is common.
Like it just feels heavy or tired.
Yeah, or just doesn't have the strength. Then there are neurosensory things, feeling too warm or too cool, numbness, tingling, even hypersensitivity. Changes in skin color, discoloration, and in more serious cases, you get tissue loss, like ulcers forming.
So when someone describes these, what specific details does the doctor need to tease out?
It's about building a really detailed picture. Key things was the onset sudden, like bang, or gradual, creeping up over time.
Acute versus chronic.
Exactly. How have the symptoms changed? Getting worse, better, staying the same. Location is vital. Where exactly is it? One leg, both. High up, down low. And the character, is it sharp, dull, burning, cramping, numb?
The quality of the feeling.
Right. And crucially, how much does it limit you? How bad is the disability?
Okay, that makes sense.
Uh.
Building the story. What about triggers?
Yes. What makes it happen or makes it worse? Activity like walking, certain positions, temperature, even odd things sometimes like vibration or pressure.
And conversely, what makes it better?
Right. Does resting help? Changing position? Medication. And finally, are there any other associated signs or symptoms or known risk factors like smoking or diabetes? It all adds pieces to the puzzle.
Got it. So let's talk about specific scenarios. The source mentions acute arterial occlusion first. Sounds serious.
It is a real emergency. The textbook talks about the classic 6 Ps.
The 6 Ps.
Yeah, it's a mnemonic. Pain usually sudden and severe. Pallor of the limb, looks pale, whitish.
Okay.
Pulselessness, can't feel a pulse below the blockage. Paresthesias, that's the numbness, tingling, pins and needles.
Wait.
Paralysis, inability to move the foot or hand. And the last one is poikilothermy.
Poikilo what?
Poikilothermy basically means the limb feels cold. It takes on the temperature of the room because there's no warm blood flowing through it properly.
Wow. Okay, so those 6 things together scream emergency.
Absolutely. Sudden, bad pain, the color change, coolness, can't feel properly. And if they can't move the limb, that's really severe ischemia. Needs urgent attention.
And what causes these sudden blockages? Is it always the same thing?
Not always. In the legs, it could be an embolus, like a clot that travels from somewhere else, often the heart, especially with conditions like atrial fibrillation.
So the person might not have had leg problems before.
Yeah, often, yes. No prior claudication, but maybe they have known AFib or had clots travel before.
Okay.
Or it could be a thrombus, a clot forming right there in a diseased artery. These patients often do have a history of claudication or maybe previous bypass surgery.
And blue toes syndrome, what's that about?
Atheroembolism. That's when tiny bits of plaque debris break off from larger arteries like the aorta.
Little fragments.
Exactly. They travel down and block the very small arteries in the toes or feet, causing that bluish discoloration. It can even be linked to kidney issues if the debris comes from near the renal arteries.
And that can just happen. or after procedures?
Both. It can happen spontaneously or sometimes after procedures where catheters are used in the arteries.
Can this happen in the arms too? Acute blockages?
Less common than in the legs, but yes, definitely.
Yeah.
Similar symptoms, pain, pallor, etc. Emboli from the heart, maybe after a heart attack, or from aneurysms higher up in the aorta or subclavian artery can travel to the arms and hands.
Okay, that covers the acute side. What about the more common gradual stuff, chronic obstructive arterial disease, or PAD?
Right, PAD. The source mentions the Rutherford classification. It's basically a way to grade severity. Starts with no symptoms, then claudication.
Claudication, that's the main symptom people associate with PAD, right? The leg pain with walking.
It is the hallmark, yes. Pain, cramping, aching, fatigue, maybe numbness comes on with a certain amount of walking, and crucially, it's relieved fairly quickly, usually within, say, 5–10 minutes, just by stopping walking.
You don't necessarily have to sit down.
Often not, just stopping the activity is enough. That predictability is key.
And does where it hurts tell you anything?
It certainly can. Pain, mostly in the buttock or thigh, often points towards problems higher up in the arterial arteries. Calf pain is more typical, with blockages lower down, like in the femoral or popliteal arteries behind the knee.
Makes sense?
Though the book notes, calf pain can sometimes happen even with arterial disease, just because the calf muscles work so hard when walking.
Any specific syndromes to know?
Well, there's Lariche syndrome. That's a classic triad. Claudication, impotence, and absent femoral pulses strongly suggest complete blockage of the aorta where it splits.
Ah, okay. Very specific.
Very.
But you mentioned earlier, sometimes the history and exam don't match. Someone might describe claudication, but their pulses feel normal at rest.
Exactly. And that could be because other health issues limit how far they can walk, so they never quite trigger the pain. Or the blockage only really limits flow during high demand, like exercise.
So what do you do then?
That's when you might need to check their pulses after they've walked a bit. Get them on a treadmill or just walk down the hall, try to reproduce the symptom, and then feel the pulses again. See if they disappear or weaken.
Ah, the post-exercise exam. Clever.
It can be very revealing.
Now, are there other things that cause leg pain with activity that aren't PA'd? Things that mimic claudication?
Oh yes, definitely. Need to rule those out. Musculoskeletal issues, like arthritis in the hip or knee. Neurologic problems are a big one, especially spinal stenosis.
Spinal stenosis, how did that mimic it?
It causes something called neurogenic claudication, pain in the legs with walking, but the pattern is often different. It might not be consistently related to how far you walk.
And how is relief different?
Big difference. With neurogenic claudication, relief often comes from changing position, especially bending forward, like leaning on a shopping cart. That opens up space in the spine. Simply stopping walking might not be enough.
Interesting. Any others?
Venous claudication can happen too, from vein problems. Feels more like a bursting pressure, takes longer to ease up, and might have swelling associated with it.
And for younger folks, especially athletes?
You think about less common things, like popliteal artery entrapment, where the artery behind the knee gets squeezed by muscles. Or chronic compartment syndrome, an overuse thing where pressure builds up in the calf muscles.
Okay, lots to consider besides just PAD. Let's move on from claudication to rest pain. That sounds worse.
It generally is. It signals more severe disease, usually develops gradually, maybe after years of claudication.
And the pain is different.
Yes. It happens without activity, often at night when lying flat. It's typically in the very distal part of the limb, the foot, the toes.
Why at night?
Because when you lie down, you lose the help of gravity, pulling blood down to the foot. Elevating the leg makes it worse.
So people find relief by
Hanging their foot over the side of the bed. That dependency helps get a little more blood flow down there. How much it wakes them up at night is often a clue to its severity.
Is rest pain considered critical limb ischemia? Same as having an ulcer.
Both rest pain and tissue loss ulcers or gangrene fall under the umbrella of critical limb ischemia, meaning the limb is threatened. Historically, tissue loss was seen as carrying a higher immediate risk of amputation, but whether the risk is truly that different from severe rest pain is still debated a bit.
And can other things mimic rest pain too?
Yes. Diabetic neuropathy is a common one. Nerve pain can cause burning, aching, hypersensitivity in the feet, but it usually doesn't get better by hanging the leg down. Complex regional pain syndrome, sometimes after an injury, can also cause severe burning pain.
Got it. What about the arms? Can you get something like claudication or rest pain there?
You can get effort discomfort, yes. Similar to leg claudication if there's significant blockage in the subclavian or axillary arteries supplying the arm. pain or fatigue with use.
And you need to differentiate that from.
Thoracic outlet syndrome. That involves compression of nerves and/or blood vessels near the collarbone and first rib. Can cause similar arm symptoms, but often has a neurological component too, maybe numbness or tingling related to specific arm positions.
Okay, that's a really thorough look at the history part.
Yeah.
Let's switch gears to the physical examination. What the doctor actually does.
Right. The hands-on part, it usually follows a system. Inspection, palpation, auscultation.
Looking, feeling, listening.
Exactly. Inspection is first just carefully looking at the limbs.
What are you looking for?
Skin changes are key. Atrophy, meaning muscle wasting. Color changes, cyanosis, which is bluishness. Mottling, a sort of patchy discoloration. Pallor, paleness, or rubor, that redness when the leg hangs down in severe cases.
You mentioned rubor and pallor before.
Yes, pallor on elevation and rubor on dependency, that's a classic sign of really poor blood flow. Also look for hair loss on the legs and feet, thickened nails, shiny or fragile skin.
Anything else during inspection?
Check for edema swelling. Where is it? How much? And critically look for any tissue loss, ulcers or gangrene. Note the location, size, depth, any signs of infection around it, and check motor function. Can they move their toes and foot normally?
Okay, so after looking comes palpation feeling. What's involved there?
First, you feel the skin temperature, compare one side to the other, check sensation too. Then the big one, the pulse exam.
Feeling for pulses everywhere?
Pretty much all the accessible ones. Carotids in the neck, then the arm pulses, subclavian if possible, axillary, brachial, radial, ulnar, abdominal, aorta. And then the legs, femoral in the groin, popliteal behind the knee.
Which can be tricky to find.
Yeah, you usually need to bend the knee a bit, relax the muscles. Then the posterior tibial, behind the inner ankle bone, and the dorsalis pedis on top of the foot.
How are they graded?
Usually something simple like absent, decreased, or normal. If a pulse feels unusually strong or wide, like bounding.
That could be an aneurysm.
Exactly.
Yeah.
A localized bulge in the artery wall. Palpation helps detect those too, especially in common spots like behind the knee, the groin, or sometimes the abdomen in thin people.
You mentioned the dorsal pedal pulse can sometimes be missing normally.
Right. About 10% of people might just not have a palpable one congenitally, so you can't rely on that single finding alone.
And for suspected popliteal entrapment.
You might check the foot pulses while actively moving the foot, flexing and pointing it to see if the pulse disappears in certain positions.
Is the Allen test part of palpation?
Sort of. It's a specific maneuver usually done when assessing the hand circulation. You compress both the radial and ulnar arteries at the wrist.
Okay.
Then have the patient clench and unclench their fist. Then you release one artery and see how quickly the color returns to the palm. Then repeat for the other artery.
What did that tell you?
It checks if both arteries are open and if the connection between them and the palmar arch is intact. Important before procedures like putting in an arterial line.
Got it. Okay, so looking, feeling, then listening. Auscultation. What are you listening for with the stethoscope?
You're listening for brutes. That's a whooshing sound.
Like turbulent flow?
Exactly. Smooth flow is silent. Turbulent flow, usually caused by a narrowing or stenosis in the artery, creates a brute.
Does the sound tell you how bad the narrowing is?
Sometimes. The pitch and duration of the sound during systole when the heart contracts can give clues. A high-pitched, long brute might mean significant stenosis.
And you mentioned another type of sound.
Yeah, if you hear a brute that continues into diastole, the heart's relaxation phase, that's unusual. It often suggests an arteriovenous fistula, an abnormal connection between an artery and a vein. Seeing more of those now because of catheter procedures.
Okay. Now, let's circle back to ulcers. The source really emphasizes differentiating the types. Why is that so critical?
Because the treatment is completely different depending on the cause. You need to know if it's mainly due to lack of blood flow ischemia or poor vein function stasis or nerve damage neuropathy, and sometimes it's a mix.
So what does an ischemic ulcer typically look like?
They tend to be painful, often worse at night, maybe relieved by dangling the foot. Usually located distally, tips of toes, maybe the heel over bony spots. The edges can look irregular or sharply defined, like punched out. The base often looks pale, grayish, not healthy granulation tissue, and often not much redness around it, surprisingly.
Contrasting with neuropathic ulcers, often seen in diabetics.
Big contrast. Neuropathic ulcers are usually painless because of the nerve damage. They might bleed easily if you probe them, often deep, maybe with a ring of callus around them, and typically located over pressure points bottom of the foot, toe joints, heel. places where sensation is lost.
And venous stasis ulcers.
Those are usually in the gaiter area around the ankle, especially the inner ankle. Often larger, shallower, irregular shape with a moist, weeping, granulating base. The surrounding skin usually shows chronic venous changes, brownish pigmentation, thickened skin, maybe varicose veins.
Are there other kinds?
Yes, the book mentions others like vasculitic ulcers, often multiple and inflamed, or hypertensive ulcers. And importantly, any ulcer that doesn't heal needs evaluation for underlying bone infection or even malignancy. Trauma or ill-fitting shoes often trigger ulcers, especially in diabetics.
How are ulcers documented? Is there a standard way?
There's a push towards more standardized assessment, noting the location, measuring the size and depth is key. Table 19.5 in the source probably details the system. Using digital photos, specific rating scales helps track progress, especially useful now with telehealth.
Right. So after you've done the history and the physical exam, how do you put it all together?
That's the synthesis part. You look at the whole picture. Do the symptoms from the history make sense with the findings from the exam? They should really act as checks and balances on each other.
The story should fit the signs.
Exactly. And often, for many arterial problems, that combination of a good history and a thorough physical exam is enough to make a pretty confident diagnosis and even predict where the blockages are likely to be.
And that leads us to telemedicine. You mentioned its increasing role.
Yeah, it's become much more prominent, especially since 2020. Though the idea isn't new in vascular care, the pandemic really accelerated its adoption, partly due to changes in how it could be billed and, safety guidelines.
What are the main pros and cons in vascular disease specifically?
Well, the pros are clear for certain things. Reviewing imaging studies remotely is easy. It reduces travel burden for patients, which is huge for some people.
Especially elderly or rural patients.
Definitely.
Hmm.
But there are limitations. Assessing someone's overall frailty can be harder remotely. That detailed pulse exam we talked about, you can't really do that hands-on via video, and sometimes complex counseling discussions are just better in person.
So what's the future look like for telehealth in this area?
It's evolving. People are working on technology for remote pulse assessment, better ways to document findings remotely. The goal is to find the right balance, using telehealth to keep vulnerable patients safely monitored at home when possible, but still bringing them in when that hands-on assessment or procedure is needed.
Okay, so wrapping up this deep dive on clinical evaluation of arteries, what are the key takeaways for listeners?
I think the main thing is understanding that really strong link between the patient's story, their history, and the physical findings. They inform each other. Recognizing different pain patterns like claudication versus rest pain, knowing what pulse changes mean, being able to spot different ulcer types, these are all crucial diagnostic skills. And just being aware that this field, like many, is adapting with tools like telemedicine.
And finally, maybe a thought to leave everyone with. Think about how this detailed, systematic approach, gathering the story, observing carefully, connecting the dots, is really just good critical thinking. It applies to understanding any complex system, right? Not just arteries.
Absolutely. Careful observation, logical deduction. It's a powerful way to approach problems in many areas.
Something to mull over. Thanks for joining us for this deep dive.